Good morning. My name is Dahl, and I'm a family doctor here in Saskatoon. So my CQIP project was to improve communication between acute care, general internal medicine, and family physicians by providing the discharge summary at the time of discharge. So we looked at the general internal medicine discharge summaries at RUH and at St. Paul's. So there were three sections to the CQIP project. The first was to establish the current state in the community. So I did a survey of 325 family physicians, got a 21% response rate, and it confirms that 96% rate that discharge summary as 10 out of 10 for importance, and 90% of them want the discharge summary faxed within 24 hours. The second part of the project was to develop a general internal medicine discharge summary template, and to my great joy, Dr. Michael Christodjecki had already developed this GIM discharge summary template as part of his CQIP project when he was a resident. So testing has demonstrated that this discharge summary template improves accuracy and it reduces dictation time on GIM CTU. 92% of family physicians indicate this GIM template for discharge summaries is useful for them. The data analysis is the third part of the CQIP project. So to change behavior, I think it's important to try and establish a gold standard for comparison. So what we did was we looked at CTU and compared it to other wards at RUH. So 81% of discharge summaries were completed in 24 hours, compared to 24% in other wards over an 18-day period in June. So for us, CTU medicine is that gold standard for discharge summaries dictated within 24 hours, and the hope is to plan to spread that success to other wards. The accountable care unit at St. Paul's Hospital was deemed a couple of weeks ago to not have significant data, statistically significant data, so additional data is being collected. For me, the data collection was the most difficult part of the project. For example, 3S Health data includes any discharge summary that has been dictated, but 3S Health is unaware if the discharge summary has not been dictated. So then you have to go to your area medical records to provide that deficiency data. And they are not automated, so that makes it makes it very difficult for them. So my personal reflections, this project was mammoth, but to me important enough to pursue. I felt that my committee members were extremely knowledgeable and gave good advice when needed. I couldn't have done this without them, so choose your committee carefully. That discharge summary provided at discharge will result in improved patient care, improved information for patients and all caregivers, improved access to your family physician, because that physician will now know that the patient has been discharged for hospital and when the follow-ups to occur. If you don't get that information, you're totally unaware that the patient has even left the hospital. So it should result in reduction in visits to emergency and readmission to acute care wards and reduction in costs. It does align with provincial and area strategies, which include the development of community health networks in Saskatoon, and there's going to be a new Nutana suburban network, which has the highest density of elderly patients in Western Canada, developed here in the fall. So the discharge summaries on these elderly patients provided to those network family physicians will be extremely important. So if you're planning a survey, you need good supports. It takes significant amounts of time and it's quite labor intensive. I would encourage HQC to develop a repository of all CQIP projects completed so we can access each other's knowledge and work. And I'd also encourage a cross-reference to other provincial CQIP projects so we can sort of build on their work as well. Improved automation in medical records would allow prompt communication with doctors if a discharge summary was not done. Quality assurance often involves manual review of the medical record, and a process is slow and can be subject to reviewer bias. So technology would make QA of the medical record more meaningful. When requesting information from medical records, be very specific about what you require, and ensures the project owner that you actually look at the raw data. So a CQIP project may not end for months or years, so one needs patience and tenacity to make changes because we have a very complex medical system. So we're just really getting started on this project. I'm very happy to know my committee is going to continue to help me work on it.